webinar. All right, now it is my great pleasure to introduce our guest speakers. And the first one is Dr. Riley N. Saligan, and he is a senior tenure investigator, Division of Intramural Research, National Institute of Nursing Research, National Institutes of Health. And Dr. Saligan is introducing clinically relevant approaches to phenotype, chronic patient occurrences, and behaviors related to cancer and chronic illness to optimize treatment and management of the conditions. And his group current research activities are intentionally developed to improve or maintain functional performance of vulnerable populations like cancer survivors. And good morning, Dr. Saligan.
Good morning. Thank you for inviting me. Can you hear me okay?
Yeah, it's okay. And our next speaker is Assistant Professor Dr. Nada Lakhahatai. And she is the director of the MS in Research Honors Program, Johns Hopkins University School of Nursing. And her research focus is to understand the biological mechanisms in the clustering of symptoms. And she is interested in developing non-pharmacological interventions to reduce symptom burden. And she also has skill to conduct complex laboratory experiments. And good morning, Dr. Nada.
Good morning. Thank you for the invite.
Very welcome. And the third speaker is lecturer Jinsuta Thatsuan. She is a faculty member at Department of Medical Nursing, Faculty of Nursing, Mahidol University. And she is currently studying in the PhD program in nursing at School of Nursing, College of Medicine, National Taiwan University. Good evening, Jinsuta.
Hey, good evening and good morning, everyone. Thank you for having me today.
All right, without further ado, I'm gonna start with the first speaker. Dr. Saligan gonna talk about concept of symptom management in people with cancer. Please welcome Dr. Saligan.
Thank you so much. If you can stop sharing, I can bring up my presentation. There. Thank you. Can you see my presentation?
Yes.
Thank you. So I'm going to talk today. The topic is really very important, especially for patients with cancer or of surviving cancer. And so I'm going to talk today about function, health, and well-being. I think these concepts really captures why, as nurses, why we work so hard to make sure that our cancer survivors maintain function, have a really optimal health, and a good well-being. So as you all know, symptoms are really complex, you know, fatigue, pain, all that. They're really hard to understand because we have different experiences of those symptoms. And so the best that we can really do is, I have a new idea of decluttering, like a messy home, you know, so many things going on. We need to just help our cancer survivors declutter them so we can understand what needs to be prioritized. What are the symptoms that are of priority that can that we can address so they can live their life, optimize their function, have a good health and well-being. So that's my presentation today. Just a disclaimer, this content is my personal views. And the objectives of my presentation is generally to give you a background on what the focus of my lab is, really to contextualize, to really understand what these symptoms are, what these experiences are. And then go into my steps on how I try to understand the symptoms using different aspects of research, such as in biology, in the clinic, as well as in the community. And then provide you, since this is a new concept, is really to provide you some examples of how I've incorporated or use community assessment to help me understand, but also forward thinking to help manage patient symptoms. So this is the orientation of my lab. The overall goal is really to improve functional performance. Functional performance, at least for our expertise, is really on physical function. We've developed, exercise interventions here in the clinic, but really to help patients have more optimally regain their physical function. We are working with collaborators who have expertise in cognitive function to help us also understand. As you know, physical function, all these symptoms doesn't come in separately or alone. They're always clustered with everything else. For example, fatigue, they don't come in as just physical exhaustion, but there's also brain fog. You can't think well, your memory's gone. So you cannot really be solitary in your approach in dealing with symptoms. You have to really collaborate with other expertise. So we're collaborating with so many expertise to help us understand and manage these symptoms. But more importantly, there are aspects in life, especially each one of us. That's why our experiences are individual. We have to really understand what's the role of the family, what's the role of the community, the environment, social, spiritual. Those areas are very important as nurses to really understand the context of their symptom experience. Here in the US, there's so many survivors, and it's growing in number because of the advances in technology. The mortality, the death rate due to cancer is going down because of advances in technology. Hence, survivorship, the number of people surviving cancer is going up. So we have that responsibility to really advance our research, our understanding, but also our clinical practice in terms of helping our cancer survivors. Unfortunately, 80% of our cancer survivors doesn't just have cancer. They have other conditions. They have high blood pressure, heart problems, diabetes. So that needs to be put into the equation, that cancer survivor also have other chronic conditions that they have to deal with. So we have to understand that. Unfortunately, especially here in the US, we have different races, of course, and each hospital or each institution provides supportive care to help cancer survivors during their treatment or after their treatment. But unfortunately, some of the minority races are less likely to seek these supportive care services that are available in the hospital. And we need to understand why and how we can engage all patients to avail of these supportive care services. So the mission, as I've said, is really to understand context and what's really going on. And I've shared this framework that's been there for a while for supportive care. And you can see it's not only physical symptoms, pain, fatigue, nausea, but there are so many other areas in supportive care that we really need to account for, how we cope, psychosocial, family, spiritual is a big driver of symptoms, such as how we view, how we perceive meaning to our life, but also health literacy, how we understand information given to us or understand information, how we digest that information and put it into practice. So we look at all these different aspects of supportive care and really use this different aspect to help understand what symptoms are. So, as I've mentioned, that's generally the entire concept of what supportive care, to look at these different aspects. Related to function, health, and well-being, I touched a little bit, but it generally is maintaining balance between all the internal and external factors that affect our health, that affect our well-being. And most of these, if they are imbalanced, they are not a balance, most of these are manifested as symptoms. So that's why we really need to regain that balance of these internal and external factors to be able to optimize well-being, health, and wellness. So our lab's approach is really to help patients declutter all these different symptoms, all these different concerns and issues surrounding their symptom experience, declutter them and help them refocus their experience so they can be linked to appropriate services that are available. And I'm going to give you an example in one of our studies on how we do that. And generally the goal is to link or to provide our cancer survivors with what services or what research studies are available that we can send our patients to. So these are the studies that I am currently doing. We have 2 observational studies, so they're generally following patients while they're doing cancer treatment or after they receive their cancer treatment. One area which I'll be discussing in the next slide is actually an older study, but we've expanded it to look at more on the social determinants of health, the community, society, the effects of family, spirituality on patients' symptom experience. And the second observational study we have is, I'm going to give you the example of how we provide this decluttering approach to connect our patients to services that are available in our hospital. And the third study we have is a clinical trial. This clinical trial is based on a marker that we found in our lab that we target to see if it has an effect in one of the symptoms, which is fatigue. So we started our study as observational, as I've mentioned to you. We followed patients who have prostate cancer, non-metastatic, and were scheduled to receive radiation therapy, localized radiation therapy. Oftentimes, these are older male, and they don't have fatigue. They seem to be functioning well. But once they receive the radiation, which are often about 38 to 42 days every day, 5 days a week. Of course, with the radiation, which is a physical stressor, all of them complain of fatigue during treatment, even after it completes the treatment on day 42. But 1 year after, their treatment, we saw that about 38% of these patients complain of persistent fatigue. So we really wanted to understand why patients, often the same age, receiving the same type of treatment with the same type of cancer, and oftentimes the same stage, why some patients complain of continuous persistent fatigue while others recover or even do better. So we try to understand that. And our group is really has the strength of doing, of incorporating lab experiments. And so we look at this as a cell to society concept. We're bringing, what our experiments, our discoveries in the lab into what the society may offer to help our patients. So with these 38% patients, we try to look at their genes and see what genomic profile is unique for these patients who complain of chronic fatigue versus those that are recovering. And we saw that those patients that continue to have fatigue 1 year after, they seem to have genes that are related to the glutamate receptor. Glutamate is is a happy hormone. So this receptor has been used a lot in psychology and psychiatry to target mood disorders, depression, and all that. So we were very interested to look at why glutamate receptor seems to be coming up a lot. So we validated this among our patients and see whether we can observe the level of this glutamate receptor gene in our non-fatiguers versus those that complain of chronic fatigue. And interestingly, we've only found the expression, these genes are expressed only in our chronic fatiguers before they receive radiation and 1 year after they receive radiation, which is really very interesting. So that's where it started. That's where our lab discovery. And now we've expanded the study, as I've mentioned, to look at different races, different groups across the United States. And we can only do this through partnership with different schools of nursing from across the country, so they can enroll specific, especially minority populations from their area. So that's what we're trying to do, to compare whether racial differences can refute or disagree with our findings, or may have other findings that may be interesting to pursue. So we wanted what the literature, what the science has been there has shown that, for example, fatigue, in such a symptom as fatigue, inflammation is always involved, even depression, the inflammation is always involved. That's really rampant. Most of the studies have really focused on inflammation, but our data, our lab discovery showed that there is a role of glutamate, the glutamate system, the glutamatergic system. So we wanted to see what is the role of glutamate receptors in the relationship of fatigue and inflammation. So we did a cell model. Since our genes were found from our lymphocytes, which includes the T cells. So we use a T cell model, which is a Jurkat cell. So we radiated the cells, which is at the bottom, and there's also a group of Jurkat cells that we didn't radiate to serve as our control. As you can see at the bottom, the top panel, the radiated cells you saw, and we put some dye to tag into the glutamate receptor. There was only one paper out there that showed that glutamate receptor can be seen or can be imaged using confocal microscopy, can be imaged in lymphocytes, and they behave like an immune cells. As we all know, glutamate receptors are often just seen in the brain. But there was one paper that showed that this glutamate receptors can also be seen in T cells. So we saw that when we radiated these T cells, the glutamate receptors clustered. They look angry, the redness. When we pre-soaked, we put these cells in a dish and put some glutamate receptor agonist to activate them. Let's say an hour. And after an hour, we radiated that cell. We saw, that's the middle panel at the bottom, the cells are redder, meaning they look angrier, if that's the word, if you compare it. So it's really very interesting. But when we pre-soaked these cells, these Jurkat cells with glutamate receptor antagonist, meaning inhibits the receptors, and then radiated them, look at the cells. There is no redness. It looked like it's the control, the very top panel. It looks like they have not been irradiated. So that really helped us rethink that probably when you inhibit a glutamate receptor, they may reduce the effects of radiation. So we tried to look at, again, the role of inflammation. So we squeezed the cells and look at levels of RANTES. RANTES is a marker of T cell activation, when T cells become active and call on other cells to bring out inflammation. So when we looked at it, as you can see in the 8th grade, the bottom figure, you can see that those cells that are pre-soaked with glutamate receptor antagonists, the RANTES level are way up compared to the irradiated or even the sham cells, those that are not irradiated cells. Well, the opposite is true with those cells that were pre-soaked with glutamate receptor antagonists. So we really, this evidence showed that altering or targeting the glutamate receptor can affect inflammation. So we looked at further and see whether, what are the upstream? We can't just look at the bottom of this inflammatory pathway. We looked at where is it coming from? Is there a pathway or a node, a bigger system that impacts inflammation from these signals? And we saw that all the genes that were upregulated actually targets or were generated from an upper pathway called the NF-kappa B. NF-kappa B is a very potent inflammatory pathway. So we looked at it and see whether if we target if we use the same model, the Jurkat cells, and see whether and investigate whether NF-kappa B is activated with radiation or altering the glutamate receptor. So we used a Jurkat cell that has a fluorescent dye called GFP, and then put different concentration of TNF-alpha. TNF-alpha is a very potent activator of NF-kappa B. And we saw at the figure in B that when we added different concentrations of TNF-alpha, that the GFP, the dye, was released in an increasing fashion. So it's a good model to detect the NF-kappa B alteration. So when we did the same model, radiation alone at the figure C, radiation alone in that white column is enough to activate NF-kappa B pathway compared to the sham. While Jurkat cells that are pre-soaked with glutamate receptor agonist, when we activate that glutamate receptor and then radiate them, the GFP intensity, the intensity of the dye are significantly higher compared to the irradiated or those cells that are pre-soaked with glutamate receptor antagonists. This gives us the confirmation that indeed, if we modify the glutamate receptor, probably it can reduce inflammation and it can reduce symptoms. That's how we created this clinical trial. We wanted to see whether if we inhibit the glutamate receptor, we can improve or we can reduce or even eradicate fatigue in our cancer survivors. So we're currently doing this study. We're using a sub-anesthetic dose of ketamine. As you know, ketamine is oftentimes it's used in the veterinarian as an anesthetic or a sedative. We use that and versus a local anesthetic, which is Versed or midazolam, and see whether we can rapidly reduce fatigue in our patients. And this is ongoing. So our initial data looks very promising. One patient who's 43 years old with prostate cancer who's an IT person, really complained that in the afternoon, especially in the afternoon, most cancer survivors, their energy levels are really down in the afternoon. That he can't do anything, he can't even think clearly. But after we gave the ketamine infusion, he had so much energy that he has to go up and down the stairs to release it. And this, of course, is being a short-acting drug, lasted for about 3 days. And that he had so much energy, and then it went back to baseline. So we are very encouraged and inspired of those types of responses. So we're continuing this study, and actually some patients have requested that we expand this study, not just on cancer survivors, but also for chronic fatigue patients. So we've expanded the study to chronic fatigue syndrome, but also to patients with lupus, with Sjogren's. So we can see whether overall, since fatigue is a global experience, we wanted to see whether overall fatigue gets reduced by just blocking the glutamate receptor. So the other study which I've talked about, I'm just going to go over very quickly, is the decluttering study. We know that it's fatigue, for example, is a complex experience, as I've mentioned. So there's a lot of questionnaires out there that's been used, especially in research. So we tried to use, for example, the PROMIS panel of questionnaires and see what specific symptoms are clustered around this complaint of fatigue. And we're hoping we can provide some list to our patients and prioritize them according to their scores. So for example, this patient came in with a lot. The higher the score, as you've seen, are higher complaints of that symptom. So he has high anxiety, of course, high fatigue, but more importantly, high sleep disturbance, which is close to 1 standard deviation, which is very significant. So with this score, we presented this to the patient during patient conference at the end of the study before we sent the patient back home. And we offer these different referrals based on their symptoms. These referrals are services that are available in our hospital. So we ask the patient that they can be referred to a psychologist to talk about their anxiety, to talk about the fatigue. But more importantly, there's also other services such as a sleep study, a clinic here in our hospital, but also talk to our pulmonary, our lung specialists, so they can really understand, evaluate further the problem with sleep. We also offer social work services to really understand, because there are other issues related to, of course, as we know, social, spiritual aspects that may help them. And the patient was complaining of snoring with the sleep. So we asked if they would like to be seen by our ENT providers to really evaluate their air passages. So we provided these options and let the patient, because our value is really let the patient drive their own care and let them select which of the services they want to avail. So that's the purpose of us trying to help declutter, but also refocus our patients' symptoms to help them understand what are most distressing among these, to help them address their symptoms and connect them to available services. So now we're going beyond on what's beyond the person, but what's available in the community that affects their symptoms. We are currently working closely with the Environmental Health Institute to help understand among the farmers. They have a huge study about 80,000 farmers that have developed or have developed cancer, have developed Parkinson's disease, and they wanted to see whether exposure to different pesticides or their injury to cancer, to their farm related injuries, cause or symptoms of chronic pain. These patients have been, or these farmers have been followed over 25 years. And we're currently looking at that and how their chronic pain, their chronic fatigue, their chronic depression and sleep problems are related to these farm-related factors. We're also working with the Cancer Survivor Network from across the country to look at how their symptoms are affecting their gut microbiome. You know, as you know, different areas in the country, I'm sure the same as in Thailand, we have different microbiome because of the way we live, the way we eat. So we try to understand what is in the microbiome that dictates unique symptom profiles among our cancer survivors. So those are the different areas. And we also have a study on how physical activity among our natives in different areas in Arizona the patterns of their physical activity are affecting their way of life, or how their culture is dictating their physical activity. So that's the end of my presentation, and I'm really looking forward to the discussion.
Thank you very much, Dr. Saligan, for your great presentation. I think your lab results is very interesting. All right. Let me take a short summary of Dr. Saligan's presentation, and he shows us about the various lab results, particularly in clinical and biological, related to symptoms in patients with cancer like fatigue, and also provide the example of research study to reduce symptoms in this group of patients. Thank you very much, Dr. Saligan. All right, we're gonna move to our second speaker. Dr. Nada gonna share about symptom management in patients living with cancer in the context of nursing. Dr. Nada, please.
Great. Thank you so much for very nice introductions. And hang on one second. Let me make sure. Can you see my slide?
Yes, already
Okay.
see your slide.
A second. All right. So thank you so much. Leo, which is actually Dr. Saligan just presenting the previous work, which actually is a very, very exciting and it's very dear study to me, to actually looking at underlying symptoms of patients, cancer patients who are actually experience these symptoms. So I'm going to actually take a little bit step further to looking at what kind of Dr. Saligan talked a little bit about the ketamine study, which actually is a study that I think it's actually a brilliant idea, and it's turned out to be pharmacological change that we can basically see in patient. For me, I'm just my focus of the presentation will be on the non-pharmacological intervention and what can we do for these patients, right? So here, actually, hang on one second, let me just see. Before I start, I would like to actually disclose that anything that I'm saying in this presentation, there is no financial conflict. I didn't get any financial support from Fitbit or any commercial wearable device. But the focus of today's talk is going to be on symptom cluster, right? Like Dr. Saligan mentioned before, that cancer patient never actually experience only one symptom. They usually come in with multiple symptoms, and they can actually sitting down with you and talk with you for hours about their multiple symptoms that they are experiencing. I also want to share with you, I'm not saying that actually I am very successful on trying to develop these personalized intervention, but I just want to share with you how I come up with the idea to develop these personalized intervention and the challenge along the way. It's not like all smooth sail and I actually like produce a really great intervention, but basically these are ongoing process, and I believe that I will continue to find something interesting and moving forward. And also, I think a lot of us are also interested in the mobile technologies as well. I think one part of that is because of the COVID-19, right? And because of these technologies, basically it make us it actually enable us to be able to be together today online. Now, as we all know, symptom is very subjective, right? And it's actually, it cannot be directly observed or measured by other. And it's actually so it's make it very, very difficult to assess and manage. I think everybody agree on this, and nurses are the front line, because we are, instead of treating cancer or treating diseases, we are actually managing symptom on the day-to-day basis. So that is actually our key responsibility, right? So, and a lot of time when we think about intervention, we usually will try to eliminate reducing symptom that the patient and the family are experiencing. Now, this is actually a very stunning statistics. In 2040, there will be 47% increase of the global cancer cases, right? I know a lot of you in Thailand probably experiencing some PM 2.5, very, very bad air at the moment. It's actually we know that actually if you're breathing polluted air, it can actually lead to the lung cancer. So we don't know how much that's going to contribute to the number of cases of the cancer in the future. But I know that a lot of us are actually either know someone who actually have cancer, or someone in the family had cancer, right? So these are actually is going to be increasing from 2020. So that's the number that we are actually dealing with in the future, right? And the people actually suffered from cluster of symptoms, 2 or more, right? It's actually, these symptoms develop, it's not just only during treatment, it's starting from diagnosis to the end of initial treatment. Most of the time they actually experience during the treatment, it's actually also continue as an extended survival. And then also a lot of time, like Dr. Saligan mentioned, cancer survival rate is actually increasing. Now, these symptoms some of the participants will continue to experience these symptoms long after they are living cancer-free, right? So with those cancer related symptoms, there are multiple factors that related to this, such as type of treatment. We know chemotherapies, radiation, and now we have immunotherapies. We actually have gene-targeted therapies, and also diagnosis procedure that actually also can lead to some of the symptom as well. And of course, a lot of us as nurses, we know that individual characteristics also play a huge role, that actually huge role in how individual express their symptom, right? So now these are actually an attempt, right? Dr. Saligan are trying to decluster. I'm just going to show you. This is actually symptom cluster that actually a lot of research team get together trying to figure out, simply because there are too many symptoms. And most of the intervention that we actually develop are usually will target one symptom. It doesn't actually target multiple symptoms, right? So we try to actually, like, perhaps if we group it a little bit better, maybe we can actually try to find the best fit intervention that can probably target a group of symptoms and it can help, right? So these are actually is a grouping based on a review of literature that I see so far and how they group symptoms together. It's from multiple study though. Now, I'm just going to share with you a little bit in my interest is because I believe that not one cancer survival experience the same thing, and not one intervention will work with every symptom. It will not. And also, even though it will work with one symptom, it doesn't work with everybody. So that actually is how I started it as a PhD student. I have Dr. Joanne Dalton here with me today. She's my PhD advisor at University of North Carolina at Chapel Hill. We start by what make people different, right? So we start there. We actually like, what make people different? Maybe it's beliefs. maybe it's personality, so that make people express their symptom differently. So we do structural equation modeling, trying to understand. And my hypothesis is maybe it's spiritual belief, because I think it probably Buddhism, and then maybe it's actually other religions that make people different. I didn't find any significant difference when the symptoms are actually very, very severe though. From that dissertation learning, I then trained as a postdoc with Dr. Sullivan, trying to pick out what is the gene. What is the gene, or what is the biological mechanism that can help us customize or personalize intervention that would work, right? So I go in, and then we actually, I think with Dr. Sullivan, we identify the drama queen genes, which actually we say it's a gene related to catastrophizing, right? And then we try to follow up that as well. Now, moving on, then there are so many things that actually happen. Cancer patient, if they are in clinical, we can follow their symptom on a daily basis. But what happened with the patient at home, right? So in 2014, I collaborating with my collaborator in Thailand, and also Dr. Inui, to actually looking at the use of mobile technologies and to see ways that we can actually monitor symptom and monitor physical activity at home, to see if that's probably would be what make people experience different symptoms. Then when I joined Hopkins, this is actually what happened. I starting to actually looking at a way to develop an intervention that include non-pharmacological intervention. I got to train with Dr. Xiaoqing Ye, who's actually expert in the ear acupressure. We know that actually a lot of us, I think many of us in Thailand probably do a couple of the acupressures, and some of you probably experience, some of you like massage, right? Some of you probably experience some relaxation or improvement of sleep, and then fatigue by going to the massage, right? But this ear acupressure is a little bit, it's go into the micro pathway, micro, it's actually a little bit smaller than when we do the body massage. So we actually found that it providing a great relief for the symptom in both cancer patient and chronic low back pain. Now, another things also that actually get me really excited about my personalized intervention is the design, the new design that called human-centered design. It actually is the design that I start learning it here too. It's similar if you're doing a community-based research. It's just like participatory action research in a way. But whenever you actually develop some sort of new intervention or new program, you basically have to take into considerations of what the user or what people who will use your intervention think about your intervention, right? So this is a principle of human-centered design in general. So you actually go in instead of like, oh, here, this is intervention, it's going to work, so just do it, and you do a randomized control trial. That usually is that's how I train that way, right? I going in, review literature, finding out what will work. Now, human-centered design go a little bit different. We probably have a little bit of the idea of what will work, but then we going in and trying to understand the population that we are working with. In this case, is cancer survival, right? So we're actually talking to cancer patient and try to understand what exactly they are experiencing and what exactly they need within that intervention, instead of from nurses' standpoint, here what you need to do, here how you need to eat, right? So we talk to the patient, and then we actually engage and continuously engage the key partner. The key partner in this case can be patient, can be provider, and it can also, even if you're doing a research, right, it can be your research assistants that actually will tell you on here, your data collection is crazy, we cannot do it, this is actually too much time consuming, right? And then looking at the system approach. So this is actually a human-centered design. So it's similar to participatory action research, but it's more in the clinical side, participatory action research, right? So this is actually lead me to start my first pilot study here at Hopkins, looking at a tailored or personalized home-based exercise program, looking at the effect of these with symptom and well-being and resilience of cancer survival, right? And now I'm gonna actually point out a few key things that I think it was a brilliant idea, but when we go into the actual implementation, it's much harder than I thought it would be. Now, the idea was, okay, a lot of people know exercise are good, but they're not doing it. And we know that actually exercise help fatigue, help pain, and help with sleeping, right? Everybody know, like us, we know as well. We keep telling patients to exercise. Now, the people are not doing as they're recommended to do exercise, right? So what should we do? So my thought is like, okay, we're looking at several research and come up with, we need to do a personalized type of exercise, because people are actually coming in with different baseline of physical capacity and physical performance, right? So we customize the exercise recommendation based on the baseline physical condition. And then we actually also providing an option for the patient on like, what type of exercise do you like? Some people like aerobic exercise, some people doesn't like it, some people want to just do yoga, some people say, oh, pattern exercise is just too crazy for me, can I just walk, right? So we allow patients to choose their physical activity, choose their time, choose the duration even, right? If they feel so like if they feel so much fatigue, they want to actually perhaps doing just 10 minutes, we will allow them to do so, to just give them from one point to another. Another thing also that we actually found through our human-centered design study is that the goal in life mattered. Simply because you would not want to exercise if you don't know why do you need to be healthy for, right? Most of the cancer patient will tell us, oh, I want to exercise because I want to be healthy, because I want to continue to live a healthy life. I still want to be with my loved one. So that is actually the life goal that we basically talk to the people before we customize their physical activity recommendation. Now, hang on one second. Another thing is we actually, because we're working with the cancer survival, these people are going home. There is no way that we will know, right? Most of the time, sometimes we do eat, like, it's just an interview. Do you exercise? And if they say yes or say no, and then that's it, right? But we want to actually get a little bit closer to the participant, to the patient. So we do the mobile health technologies. We use Fitbit, we do smartphone application. And then we do a symptom survey on a daily basis to see how they experience, what is their experience. And also we use that as a tool to check the compliance, to see how is their step count change, is their active minute change, right? We're also using the application to provide a meaningful feedback on, oh, you did great today, you just meet your physical activity goals. And we use that data that come to our platform to guide our weekly recommendation as well, right? And we also encourage people to do exercise at home, or if they have access to the gym, they can go to the gym as well. But because we think exercise at home are convenient and it's basically is low cost. So we start by doing an open label trial for 4 weeks, looking at the feasibility. We're doing a home visit. We're doing training people to exercise at home, because we want to make sure that people can safely exercise at home. Let me actually, for the full disclosure, this is actually before COVID-19. So we're going to their home, we exercise with them at home, we check with their life goal, we actually monitor them through Fitbit. Then with that 4 week, we actually have an interview with both patient and the interventionist to see what type of training do we need if we want to do these personalized intervention, and also what kind of elements, and with these application that the participant use, what kind of barrier and things, right? So we actually interview both patients, and also we have a focus group for our research assistants as well to actually come up with these idea. With the 12-week, we expand the program to 12-week exercise program, personalized weekly recommendation for the physical activity. It is a combination of the home visit and the phone follow-up, right? These are inclusion criteria. What unique about our study for this pilot study is that we're looking at, of course, we're looking at cancer survival who complete treatment. Another thing that we actually looking at is most intervention study will actually recruit only cancer patients who didn't have any comorbidity. Our study are actually, like Dr. Saligan give such a very nice introduction that he said, it's never actually just cancer alone. They always will have some other comorbidities such as hypertension and diabetes, which are actually two of the most frequent comorbidity of cancer diagnosis patient, right? So we include these participants. We actually just only focus on the participant who have other comorbidity. And then on top of that, I thought it was a brilliant idea, because the thing is, cancer patient, a lot of study, we actually can get cancer patient from variety of socioeconomic status. We don't really know what happened with cancer patient who are in the low socioeconomic status group, right? So we want to actually target at those, want to know what is their physical activity look like and how can we actually promote physical activity, right? Little that I know, I thought, well, that's a brilliant idea, because it was no one really know, right? So I start there. The problem is the recruitment is very difficult. And then another thing is actually you use mobile health, right? You actually end up with mobile health literacy issue, the use of technologies, the availability of the technology, which I think it's a learning curve. It's a huge learning curve for me there. But it actually is a very, very interesting to work with these specific populations and try to go to their home, training them to exercise, and then moving from one point to another. So now this is actually our result. Basically, we have 10 participants in the control group. Well, if you ask, why is it so little? I will tell you in just a little bit. The intervention group, there are 14 participants in the intervention group. It's a randomized control trial for that adjusted 12-week program, right? What we see is actually, like, from these, we can see pretty balanced compatible between the control and intervention group. And the age range is about 73 to 74 for both group. Now, when we actually looking at this, we start by looking at, okay, we want to see if physical activity does make any difference in terms of symptom report at all. We actually see that if we divided the participants based on the Fitbit data alone to the active group, right? We're not considering any of the control and intervention group yet. We're looking just only the level of physical activity. And we found that the active group actually reported lower fatigue and fatigability, right? And the effect size is it's moderate effect size, which actually we thought that was actually confirmed our decision, right? Now, moving on, this is actually the comparison between the control and intervention group, right? Because of the small sample size, we can only report what is the trend of the improvement. And we see that the participants in the intervention group report less fatigue, reductions of fatigue, reduction of pain, while the people in the control reported increased pain and fatigue, right? Also, we see some other improvement of the other variable as well, like physical well-being, mental well-being, and resilience. So that's actually is what we see. Now, during the trial, of course, we are actually, because it's a 12-week, right? It's a very long, it's quite long follow-up. Now we actually have a couple of the drop-off. We have a little bit bigger dropout from the control group with the 24% drop-off from the intervention group. And a lot of time patients are saying, I'm not only experiencing fatigue, I experience some other things too. And a lot of time people didn't meet their exercise recommendation or exercise goal simply because some of them are actually, I have a knee pain this week, it's pretty bad, so I couldn't walk. So that's why I didn't actually exercise as much, right? Now, what happened there? Why did you have only a few people in the control and intervention group? COVID-19 happened. It's actually like all research activity were on pause, right? On hold in March 8, 2020. When that actually happened, we try everywhere we can, right? So we basically get the IRB approval to continue an online follow-up phone calls and things. So the things that actually help us the most is the participant told us that they've waiting. The valuable of the study is they've been waiting for our phone call, and they find the phone call, the week call that made with them is meaningful, and it's actually feel like somebody care that what they are doing during the quarantine and during when we actually everybody have to stay home, right? So that it actually is leading us to the next phase of my study. I'm going to really fast on this. This is actually what lead me to start thinking, okay, if the phone call is something that will connect us to the patient, maybe we can actually try some other things as well. If we can turn everything into a virtual training. And another things that I also think is actually with the application, with the smartphone that we use, they are limited feature that we can improve, that we can basically help patients feel that we are with them, even though we're not with them physically, right? So that leads me to this. We turn everything into virtual training, right? It's crazy when we're starting this physical activity and the other thing. Another thing also I mentioned a while ago with the issue with the people didn't actually meet their recommended weekly physical activity goals simply because they experience other symptoms. So we decided to start something a little bit more complicated by combining exercise with other non-pharmacological interventions such as ear acupressure and also mindfulness-based intervention as well. So we turn everything into the virtual training. We improve our symptom monitoring application, right? So we make it a little bit more user-friendly because we got some feedback from the participants that the previous one that we use is not that friendly and it's very complicated. And sometimes patients say it's annoying. So we actually like, okay, let me just try to find it a little bit more simpler that way. Now, we also using all this and sending it to the participant on the phone, right? So it's actually again, it's actually helped literacy in terms of using the mobile technologies as well. So we're sending these survey to the participant phone, and the data will come back to us. It actually have a back, which actually is a staff side platform that we actually looking at that data. We generated the weekly progress report to actually send a response to the participant to show them we are looking at your physical activity and we actually monitor your symptom survey, your response on the symptom. You're not alone. We are watching you basically. And then we send it back to the participant on the same app, right? So they got a weekly progress report. That weekly progress report was also used by the research team to come up with a weekly recommendation, right? So those are actually is a platform that we send it out. Okay, here's your weekly goal. Seems like you work 5,000 steps. How about this week? We increase a little bit more, like 5,200 steps per day, and see if you can achieve that goal. So that actually also will be sent through the smartphone application as well. So as a proof of concept, right? we thought, okay, let's just prove if the combined intervention would work and if it's feasible to do, right? So we also want to see if that combined intervention would help patient better than just exercise alone, right? Because these are actually all evidence-based intervention. So we do exercise only. We compare with the combined intervention like exercise plus acupressure. We actually recommended acupressure based on the pain point, based on the fatigue symptom, depends on what symptom that the participant want to focus on that specific week. And then the mindfulness, which actually we're looking at just simple body scan, mindfulness breathing, mindfulness meditation, which actually will help reduce some of their stress, to see if just doing like a little bit more relaxation will help with their physical activity, and if whether or not it will help with their symptom at all. Now, this is actually what it looked like in our application, right? We use Fitbit still. So the Fitbit actually have these platform that we can actually extract the data as a researcher. We use it to combine with the application that we developed. We sent out the daily survey on 9 a.m. on a daily basis, and the participants respond to those message, right? Also, we on Monday, every Monday, we sending out a goal setting for physical activity for each week and monitor the participant on Sunday to see, it's actually called achievement survey on Sunday to see how they are actually exercise and how they are comply with all of the interventions. So those are actually are sending in and out through the smartphone application that we do. And this is actually is a personalized ear acupressure. So they are a point that we actually use, like attunement point that actually help with stress. And then there are some endocrine, there are some subcortex that actually can, it was recommended for fatigue symptom. There are some point that recommended for problem with insomnia. And then there are point that actually help with some of the body pain point as well. So the recommendation also with the picture of the ear point or the point on the ear will also send it to the participant on the phone. But before they can do that, we're doing a virtual training and back demonstration to make sure that the participant know how to locate the ear point and how to actually place the seed, how they can stimulate the ear point. The last combination is exercise plus mindfulness. We only actually add 10 to 15 minutes per day to include some of the mindfulness technique. We are not doing a full 8-week mindfulness stress reduction or mindfulness cognitive behavioral therapies, just a few technique that can help them reduce some of their stress or maybe problem with insomnia, right? So now, these are actually actively recruiting. So these are aimed. We want to see the feasibility of combining the intervention. We want to see if any of these interventions have any impact on the biomarker at all. There are some biomarker which actually, I think Dr. Saligan already gave us a very broad information about that biomarker. So I'm not going to focus on that for my presentation. But and also we want to see, beside the feasibility, we also want to see if the combined intervention would give a better effectiveness on the symptom and physical activity in general, right? So this is just a proof of concept. We just come up with that idea during, we actually like, we stay home too much during the COVID-19. So we come up with this idea, this crazy idea of combine so many things. But with these participants, it's actually a proof of concept. We do a randomized control trial. There are actually 5 different arms. It's actually 5 intervention, and we measure outcome looking at some of the blood biomarker as well. Now, these are inclusion and exclusion criteria. There are a grant from Oncology Nursing Foundation that they want to focus on participants during immunotherapies, right? So that's why our population are not focusing on just cancer survival, but we also adding on the new population, which actually is the patient during treatment. So those are participants that we are actually recruiting at the moment. And based on what we learned from the first pilot study, we actually, instead of just broadly recruit anybody, we specifically asking the participant should have their smartphone, because when we're doing a low socioeconomic status population, some of them don't have smartphone. When they don't have smartphone, that's actually is creating some of additional requirements, and we don't know if our app or our intervention doesn't work. So we want to actually make sure that the app is stable enough, and it's actually, we will expand later, but for this trial, we just want the participant who already have the smartphone and familiar with the use of the smartphone. So now, this is an active recruitment study, and it's a funded study. So right now we actually recruit 46 participants who are receiving immunotherapies and 30 cancer survival, because we also want to expand from our previous trial. So we're looking at cancer patients who complete their treatment as well. So far, we don't see serious adverse event, which actually that's great. Now we actually have about 20% protocol deviation. What it means is actually it means that we sometimes patient during their immunotherapies, we cannot draw their blood simply because of there are some limitation, their vein is not good, so we didn't get their blood. And then also a lot of time when we actually are doing all of these virtually, when we schedule a second or first visit, asking the participant to come see us to draw blood, simply because we need the biomarker, right? We actually we couldn't actually get them to come back on the time frame, simply because a lot of time they have busy schedule and the other things. We have about approximately 25% dropout, and a lot of time it's actually in the control group, because they feel like you didn't do anything with us, you just monitor the physical activity, right? Based on the participant feedback so far, we actually patients are satisfied with the training, online training. A lot of time they request an online training because they feel like the travel can be a challenge, and a lot of participants who are actually from out of state can participate in this study as well. The new application get a pretty good feedback that it's actually user-friendly and it was not a burden. And then also there is actually the application that actually using the ear seed. They felt, some of them felt that it was a little bit difficult to actually just do a virtual training, simply because you can't see ear. When you're actually talking about tiny point on the ear, it's actually even harder. And a lot of time you can't put the seed on the ear. So sometimes they require caregiver assistance. So that could be something that we can look into in the future. Fitbit is easy to use, so a lot of them are actually pretty happy with their Fitbit. Now, the interventionist side, what is their feedback? They feel like the staff interface of the app is much user-friendly compared to the previous one that we used from the previous trial. Also, the Fitbit data, it's helpful. The problem is they have to go into the Fitbit platform to actually extract the data. So they suggested that if the Fitbit data can be integrated to our new developed application, that will be better. Now, also, they feel like some of the participants require additional assistance with application, Fitbit, and then also virtual training, especially with the ear. Some of them are requesting an in-person visit training to actually get to know, okay, here's my ear, and here's how I locate the seed, and here how I put the seed on, and here's how I simulated the seed, right? So these are actually, before I end my presentation, I want to acknowledge funding resources. So these studies are basically funded by the Promote Center from Johns Hopkins and also the Oncology Nursing Foundation. Thank you for them, because I couldn't be doing this without their support. Also, I would like to acknowledge the contributions of all my cancer survival, and of course, all of my advisor and mentor who actually working with me throughout. I learn each and every step that I take is actually I'm learning from you guys. So, and then also providers from the Cancer Center here at Hopkins, symptom science and home exercise research staff who are actually wonderful, working on recruitment, seeing patients, and the patient are very happy about our program simply because I have the greatest research staff that helped me with the data collections and connected with the participants. And the last but not least, all my friends and collaborators that helping me throughout the program. I couldn't do these research without every one of you. And this is actually my contact information. And I am also looking forward for the discussion and questions that you guys may have after this.
Thank you very much, Dr. Nada, for your valuable sharing. All right, let me take a short summary of this talk. And Dr. Nada mentioned about symptom cluster. And also she showed us several non-pharmacological interventions in people living with cancer, like mobile health to monitor and manage symptoms. All right, we have come to the last speaker. Lecturer Jinstar is going to talk about health technology in cancer care. And please welcome Lecturer Jinstar.
Thank you. Thank you so much again for having me today. I'm very grateful for this opportunity to be a speaker in this webinar meeting. So after Dr. Saligon and Dr. Nada have already give you a very wonderful presentations, and Dr. Nada have already talked about the health technologies. And for my presentation, I would like to share with you about the health technologies, but just mostly focus in Thailand, that what we are having now in Thailand and what is going on here. Okay, let me share my slide. Can you see my slide?
Yes.
Okay, thank you. Okay. Okay, this is my outline that I would like to follow this flow. First, I would like to talk about the situation of cancer care in Thailand, and then move to the technology in Thailand, that what we are using today, and then just show about the research about the technology that we use in cancer care. And the last topic is about challenges and barriers that we should really pay attention to. So for this slide show the situation of cancer in Thailand. According to the last data in 2020 from WHO, you know, cancer is a growing concern in Thailand. You can see from the slide that the top 5 of cancer in both sex and all ages. First, the most common one is liver, is responsible for 14%, and followed by lung cancer, breast, colorectal, and cervical cancer. So these top 5 contribute to over half of cancer cases in Thailand. Let's see the number of cancer cases in different sections. WHO also report that liver cancer is the most common cancer in men, and followed by the lung cancer, colorectal, and prostate. And for a female, the breast cancer is the most common, and followed by colorectal, and cervix, liver, and lung cancer. Let's talk about the problem of cancer care in Thailand. We have several problems in cancer care in Thailand. You know, first is a shortage of medical oncologists. Do you know that approximately 200,000 people are diagnosed with cancer each year in Thailand, but there are less than 300 medical oncologists to treat them. And the second is the cancer patients, especially those in rural area, they receive inadequate cancer care. Because many factors like distance from the patient home or to the nearest oncology clinic, or the cost of travel. And moreover, similar to low and middle income countries, the newest treatments are not affordable for many patients, which limits who can receive them. And another problem that is a large number of Thai people with cancer are diagnosed with advanced stage. This leads to a lower chance of a cure and poor treatment outcomes and a poorer quality of life. That this is we are facing now in Thailand. And technology is move very fast and is play an important role in our society and personal life. And now with the pandemic, we have seen the development, adoption, and integrations of many new technologies. You can see on the screen that we have mobile application like Dr. Nada already presented you, and virtual reality, store and forward telemedicine, AI or artificial intelligence, or telepathology, telegenetics. And for today, I will focus on the first of three technologies. In the past few years, we have seen the rise of mobile networks from 1G to 5G. The whole process of mobile networks evolution from 1G to 5G has taken over 40 years. So you can see the first is 1G, the first generations, that it basically was a network with only voice call, and speed was extremely slow. And for 2G and 3G, 2G is just we can add text messaging, and for 3G is we can just start use the internet, but the speed is also very slow. And for 4G, speed of 4G is much faster than 3Gs. And now is the era of 5Gs. It's an era of internet of everything. It will be the backbone of technologies than other communication areas with high-speed network. Actually, in Thailand, mobile apps are used in many health centers. However, in Thailand, there hasn't been much research on the effectiveness of mobile application. Sorry. And for example, in Thailand, I'm pretty sure that in many health centers, especially in hospital, like Sirirat Hospital, and in Bangkok and UBCHEC, Sirirat Connect, we have this kind of application that allows patients to make appointment with their healthcare provider, and they can see their medical history. And on the right-hand side is Cancer Anywhere, that in Thailand now this application is one of the National Health Security Office is initiative that effectively ensure that people can access to the costly treatment that allow cancer patients under universal coverage scheme to request that treatment at any private hospital, regardless of their registry hospital. It means that, for example, if that patients who live in rural area and in that area they don't have the oncologist in the nearest area, there is no hospital that they have oncologists, so they can go to get the treatment from any hospital in Thailand who have expertise in specialized in cancer. So this is the new policy that we have now, but unfortunately, we don't have the research that tests the effectiveness of this kind of application yet. And this application also from National Cancer Institute in Thailand. So this kind of application, they provide the general knowledge about the cancer, such as the cancer prevention guideline or the section about the article that easy to understand for the public, and cancer news, and patients can contact the cancer center via this application. So in Thailand, so far, there is a pilot study that developed a smartphone application, namely Lung Cancer Care, for cell reporting and cell assessment for quality of life and the side effect from the treatment, such as chemotherapy, targeted therapies or immunotherapies in patients with advanced non-small cell lung cancer during COVID pandemic. They test the hypothesis that lung cancer care applications can improve quality of life and survival among patients with advanced non-small cell lung cancer when compared to the patient under routine care. And this data was collected in Pramongkutgao Hospital. And it just, as I say, that it's a pilot study. So they have about 30 with advanced non-small cell lung cancer. 17 patients were randomly assigned to use application, and 16 were monitored with the routine care. The outcome were measured 3 times, including baseline, week 4, and at 3 months. In the application, when we enter the application, we will see the questionnaire consists of 2 parts, which on the left hand side is they assess the quality of life by using FACTL, FACTL, this is a questionnaire. And the right hand side is about the symptoms related to adverse events from the treatment, and also use the CTCAE questionnaire. So after the staff or healthcare provider receive the information from patients, they would manage their case by replying instant advice and real-time response, or directly contact. But it depends on the severity of the patient reported outcome result. For example, if the patient report that, and then the application will analyze that the score is, if more than the cut point, the staff will direct contact for a pain management, maybe like phone call. But if there's the outcome show that is not severe, just grade 1 or 2, and they just give the advice and pop up into the application. And for the result, if the result is grade 3 to 4, they also call the patients. And the study showed that patient using application had a trend for a better quality of life score than patients who were monitored with routine care. So as I say that we still have limitations because it's a pilot study and just published last year. So we still need more further research in Thailand. So yeah, it's very challenging. And we are waiting for Dr. Nada intervention. And okay, this slide shows the feature of the lung cancer care application in Thai version. Okay, this just shows the technologies, but we don't, in Thailand, we still don't have this to take care of patients with cancer. But I just wanted to show you that we have this kind of technology in in Western country is visual reality is the detection method defined as a non-invasive simulation technology, which allow user to interact in the clinic, interact with the virtual world. And recent year, VR has become popular in clinical research study and used in the cancer field because the research also show that it can relieve the symptoms such as pain, stress, and depressions or fatigue, nausea, and others. And however, as I say, in Thailand, there are no research on the use of VR in cancer care. But in Thailand, we just begin to use VR in education and psychiatric area, like in Somdet Sao Phaya Institute of Psychiatric, they apply VR to treat anxiety, phobia, or post-traumatic stress disorder or PTSD. But it just starts. So it's very challenging for cancer patients that Thai people that how to develop in Thailand because it needs resources, many resources. And however, this technology is still have drawbacks such as the cyber sickness or motion sickness and patient discomfort or equipment costs and others. This kind of technology is also they are used in many developing, not developing, in developed country like US or Western countries. In Thailand, there is no research on the use of telemedicines in cancer patients. Telemedicine is a modern technology. Typically, the telemedicine works in two ways, which is real time or video and store and forward. It's very benefits for people who are stuck in any conditions and cannot go far away from checkup or treatment, and they can visit the nearest health center and get treatment. Moreover, telemedicine is very useful for people in rural areas. So in rural area, during an emergency, people can visit the nearest healthcare center and can get the treatment. For example, if patients who are in rural area, but there is no oncologist there, they can have a video conference, video consultations with the doctor in other hospital. But even in the other country, like we are in Thailand, but we use telemedicine with the oncologists in other country, like in the US. So, but this is also very, very challenging. I can say that because you can see on the picture that we need a lot of resources like database or device, and we need a medical device that have their sensor or wearable, and this sensor, like we need a blood pressure or pulse rate, and we have to have that devices to transform the value to the doctor in database. And yeah, they have to have a strong internet connection. But this very challenging for Thailand also because if we can do it, we can improve the quality of life of cancer patients. Okay, and the last topic that I would like to pay attention to, which are the challenges and barriers. So, you know, in developing country like Thailand we face many challenges and barriers. The first one is access to internet connection. You know, the lack of access to technology, poor internet connection, especially in developing countries, like Thailand, as I say, very important barrier that obstruct communication and interaction through video consultations. In the video consultations or video conference, we need high quality cameras. We need internet connections must be strong. However, in low or middle income countries, very expensive, high quality camera are not affordable. It's not affordable, especially in rural area. So the video call methods for telehealth is sometimes it's not practical in the low or middle income countries. For this issue, from my point of view, we need the support from governments by increasing the data transfer capacity of the internet networks and the instrument of higher generations of network technologies. And I think that poor infrastructure was very significant difficulties in developing country, which call for the national effort. So we need the national efforts to provide adequate strategy and planning and provision of the resources. So it's not easy. And for the number two is several studies report that the issue of piracy and data security is very challenging and barrier because this concern remain a major limitation. It's crucial to utilize technology in healthcare without infringing patient data. For example, in the research study, when we decide the application, we need to design and set the setting that allow all the people who register and authorize user. Study also emphasize in obtaining informed consent, which should follow the country laws or legislation, and adequate information might be provided to the patients. And additionally, the provider should notify the patients about the use of any third-party applications during a telehealth consultations because of their accompanying cybersecurity risks, and they have a possibility of breaching their patient data while using this application. And for the third is technical aspect. This issue, some patients are unfamiliar with the technology, and some patients that discomfort with technology. So we have to design that the design should be easy and not too complicated. And we should not, in my opinion, we should not overwhelm patients with too much technologies. To benefit from technology assistance, we must be willing to adapt our care routine and incorporate technologies into daily workflow. So we should not overwhelm them too much technologies. And the last challenge, is healthcare professional and patient relationship, because technology lack an essential elements of the nurse-patient relationship, that is human touch. So patients may not be capable of convey all their concerns compared to in-person visits. So patients said that they feel relief when they see their nurses and their doctor in office rather than video consultants. From my point of view, according to this issue, technology is just supplementary to oncology care, because it just extends oncology nursing and our care to patients and family at home who otherwise would be alone. So technology cannot replace our interaction with patients, but it just allow us to be there for patients to notify us when they need additional support. So this brings us to the end, and thank you for your time and your attention, and thank you so much.
Thank you very much, Jinta, for your great talk. And all right, we have moved to the Q&A session that we can see in the chat box that the audience send the questions that two of our speakers already respond in the chat box that you can see there. And as we are running out of time, I will have just only one question for our speaker today. Do you have any suggestion for the nurse or other healthcare providers to conduct the lab exam or to develop the new health technology to control or manage the symptom in patients living with cancer? Shall we begin with Dr. Saligan? Dr. Saligan, please.